So thank you, and I do apologize for the delay because I was in some other session. I would be talking to you. I'm sure you would have discussed everything about endophthalmitis, but I would be talking to you steps in preserving corneal health in endophthalmitis. And cornea can be involved not only in endophthalmitis but also TAS. Having said this, even after doing a corneal graft, one can get keratitis and endophthalmitis. It is important to differentiate TAS from endophthalmitis, and one very important sign therein would be severe limbus to limbus involvement, which occurs in TAS, and there is corneal edema, unlike in endophthalmitis, where it may be just mild. Histologically, if you see, then TAS specimens do have shown various changes like decreased endothelial cell density, structurally disturbed collagen bonds, epithelial cell layer changes, and stromal edema, fibrinous membrane over the Descemet's membrane with several layers of elongated fibroblasts, etc. And there can be complications also because of TAS, such as endothelial cell loss, epithelial downgrowth, and secondary glaucoma, raised intraocular pressure, which can again cause corneal edema. The management of such cases remains essentially topical steroids, and increasing severity, gel steroids can be given, topical NSAIDs, IOP management, and refractory cases, people have even tried recombinant tissue plasminogen. Now, resolution of TAS with medical management can occur, such as in this case, when over a period of time the cornea does clear up. Surgically, it would depend on the severity and etiology, and it has been shown that 30% of the cases would require some kind of surgical intervention, endothelial decompensation if it is there, and not getting treated by the medical management for 6 weeks. You may have to do an endothelial keratoplasty or full thickness keratoplasty, and generally one has to wait for 3 to 6 months for optimal visual results. After having TAS, when you do endothelial keratoplasty, if you don't wait, then there's every chance that even in the secondary surgery that you do, there may be TAS and there may be increased reaction. So it is imperative to wait for at least 6 months after TAS if you have to do endothelial keratoplasty. And refractory glaucoma cases may also require filtering surgery. This is the publication that we've done of DSEC in TAS, and visual acuities work good. They do recover well. Of course, prevention is more important in these cases, just like in endophthalmitis, taking every care that these don't occur. As far as endophthalmitis is concerned, there may be cases where cornea is not involved at all, and there may be cases where there are corneal infiltrates present, or this generally is related to the wound abnormalities which may be there after cataract surgery. Corneal incision has classically been implicated, especially in the earlier studies where it was believed that clear corneal incision has greater incidence of TAS as compared to scleral incision, and ECC has more endophthalmitis as compared to phaco, and clear corneal incision has more endophthalmitis as compared to the scleral tunnel infections. Preoperatively, it is very important to see that the ocular surface is optimally managed, especially in patients who have atopic disease, or patients with rosacea, mebomitis, blepharitis, and even systemic conditions like diabetes may cause delayed in wound healing, especially the wounds of the cataract surgery. As far as the corneal incision is concerned, like I said, size of incision is important, location of incision is also important, and it is imperative that there is no wound leak after the surgery has been done intraocularly, and one should always check for the water tightness of the incision. And wound management is vital because you cannot afford to have hypotony, and you can't afford to have wounds which leak. Now, the corneal involvement can be in the form of corneal infiltrates, corneal edema, corneal opacities, and endothelium precipitates on the cornea. This is a case of corneal tunnel infection, tunnel infection, which is actually going onto the cornea with endophthalmitis after SICS. And then you can have endophthalmitis with complete involvement also of the cornea, as seen on the picture on the right. Apart from this, there can be keratitic precipitates as well. Now, it is important that in these cases of endophthalmitis, if vitrectomy is required, it is done early, because if it is done later, then the corneal changes may ensue, and that may impede the visualization, and it may vitrectomy or surgery may become difficult. With the edematous cornea, like I said, keratotic precipitates on the corneal endothelium may be there, and delayed onset manifestations of endophthalmitis also include band keratopathy and corneal opacification. Now, corneal edema can be epithelial edema or can be because of the infection itself, and sometimes it just gets cleared by the topical steroids and by anti-glaucoma medications. And there has been a meta-analysis which has very clearly shown that CCI or clear corneal incision is a risk factor where increased endophthalmitis rates of 0.189% were seen as compared to rates of 0.074%, which is seen in the scleral tunnel incisions. And in the ESCR study, the clear corneal incision was found to have 5.8 times more likely to contract endophthalmitis than patients undergoing scleral tunnel technique. Now, apart from this, the corneal infiltrates can be there, and again, they can be localized or they can be diffuse, and these have to be treated with topical antibiotics, as well as you may require even intrastromal or intracameral drugs, especially if the infection is due to fungal organism. And at times, the situation gets so worse that you may require a temporary keratoprosthesis plus vitrectomy, core vitrectomy for the infection, or complete vitrectomy, as I think as they do nowadays, along with a penetrating keratoplasty. And this is just to show vitrectomy, which is done through the hazy cornea in these cases of endophthalmitis. And sometimes the situation can be like this, where in a graft you have corneal infiltrates as well as endophthalmitis which is present. So this is in fact a case of keratoprosthesis where endophthalmitis was there, and in this case the vitrectomy was done, and subsequently the keratoprosthesis was replaced with the help of a penetrating keratoplasty, which was a therapeutic graft. So suffice it to say that cornea may be involved, may not be involved, or may be involved only subtly, or there may be frank infiltrates which may be present with keratitis, or it may be a full-blown keratitis with endophthalmitis, and all these spectrum of corneal involvement would require separate lines of management, which I have discussed, and one needs to be sensitized to that. Thank you very much for your kind attention.
Thank you, ma'am. A couple of questions for you. Is one of the things is many a times when the view is not clear, when the retina surgeon wants to do a vitrectomy, he cleans up the cornea by scraping the corneal epithelium. How quickly would you recommend starting the topical steroids in these cases who are already infected? Is there an additional risk that the infection might spread onto the cornea?
Epithelial debridement would definitely be an additional risk factor for infection, and so topical steroids I would perhaps start on day 3 when at least epithelium starts to come up. Also in these cases you can also put glycerine on the surface of the cornea, so that itself will cause some clearing of the cornea and will allow you to do a vitrectomy.
How about putting a bandage contact lens in such situations? Is because contact lens itself per se might be considered as a potential source of infection.
From the cornea point of view, if you ask me, I would rather not put bandage contact lens but do a lateral tarsography in these cases because bandage contact lens is also a nidus for infection.
Right. Thank you very much, ma'am.
There are some cases we see that there is a ring infiltrate which starts developing. Typically, when there is a scleral involvement is also there, it tends to spread. Is there any, can that get us a idea about what kind of organism we are looking at, what kind of organisms cause these kind of presentation? That might give us.
So ring infiltrates classically would occur in cases of acanthamoeba keratitis. But having said this, there are series where ring infiltrates are not associated with organisms, and they have been associated with all sorts of organisms. So I think we cannot definitely say that if the ring infiltrate is there, then it is A type of organism or B. That has to be microbiologically proven. And I'm sure you would have, when you give intravitreals, would have a vitreous tap. So that would be a more definitive way of knowing which organism it is.